So our next speaker is Natalie Pitt, who's director at Silver Thomas Hanley in Melbourne. She has 20 years of experience in planning, designing healthcare, and using two recent projects in Australia as an example, she is going to talk about how does a model of care inspire different health architecture. So let's welcome Ms. Natalie Pitt.
Firstly, thank you to the Academy for this opportunity to present today, and also to Alan, of course. I think this presentation hopefully follows on in a very nice order from some of Mary's discussions there about mental health design as well. The model of care is an important design tool. Different models of care have inspired unique healthcare solutions in diverse healthcare settings, both locally and internationally. Regardless of context and setting, alternative models of care have informed our health architecture to bring real improvements to patient behaviour and clinical outcomes in healthcare settings. We believe this appreciation enables the creation of spaces to foster partnerships with staff, patients and carers. Today's paper will examine two different from the norm case studies from Australia. In each case, the project outcomes will be reviewed to compile the successes and learnings from both projects. The built environment will be reviewed according to key functional components and their resultant solutions. I'm Natalie Pitt, I'm a director at Silver Thomas Hanley. We're a national and international healthcare design practice, and we have over 130 specialist healthcare design staff throughout Australia. Our design approach is characterised by extensive collaboration to create positive therapeutic care environments. We are firm believers in consulting with stakeholders and believe the best design will only come from working in a creative partnership. It is from lessons learnt and post-occupancy evaluations that our design process has developed, and it respects cultural diversity, healing environments, practical user interaction, to arrive at sustainable, salutogenic healthcare solutions. As many of you might be aware, the slide here really represents the traditional design process where we go through a master plan, feasibility, schematic design, design development, then onwards to documentation sort of a process. However, there's a few pieces of the puzzle here that are missing in this process which we believe become an integral part of creating a slightly different architecture. There's always a functional brief, there's often a business case, a service plan, and if you're lucky there might be a study to it, but importantly, international benchmarking. There's another component here which we need to talk about, which is the model of care. The patient journey is a really important part of understanding the model of care. The model of care is often a strategic document which creates new ways of thinking and new and aspirational ideas as to how a facility may work when it's up and operational. By embracing the model of care, we are striving to create positive healing environments to encourage better partnerships with patients, carers and their families. As such, the design solution can celebrate the patient journey. The benefits and challenges of this approach will be also discussed. Firstly, I will talk about the Professor Marie Bashir Centre at Royal Prince Alfred in Sydney, and secondly, I'll refer to the Acquired Brain Injury Centre at Caulfield Hospital in Melbourne. Our client was the New South Wales Department of Health Infrastructure, and we worked closely with Royal Prince Alfred staff and patient advocates to realise the design outcome. STH as health architects collaborated with Peck von Hartel as design architects. The centre we have created is a building which people do not necessarily inhabit by choice. No one necessarily wants to be in a mental health facility. This very challenge inspired our team to consider the idea of community and neighbourhood and how this could be translated into an interior solution which engages with the local context to drive interior outcomes. It's a $70 million Australian redevelopment. It commenced in January 2013 and it's a fully integrated rapid centre for access to psychiatric care. It was completed in 2014 and as an 18,000 metre squared centre. I want to take a moment to talk about the model of care for this project. So the themes, the care themes. First one was getting better together. And on the day of the opening of this building, everyone was handed a badge that said getting better together. So we all really took that on board as a really special theme of this project. We had a shift from standardised care to an integrated continuum of care where it's all provided under one roof. Now this included emergency care. We had health promotion through sustainable development and quality through academic medicine. We had a collaborative, non-observational model of care and a place for visitors and patients and staff. And ultimately, it was a community facility. This is the main entry to the building as it stands. The Professor Dame Marie Bashir Centre is located within the Royal Prince Alfred Camperdown campus. So it's directly across the road, it's on Missenden Road, immediately across the road from the main RPA site, which is one of Australia's largest tertiary teaching hospitals, and it's also within close proximity to the University of Sydney. It is a contemporary, purpose-built mental health centre and provides accommodation across 6 floors. This is the first in its configuration in Australia on a multi-level type arrangement. This is the main entry lobby. The centre comprises of a dedicated emergency assessment unit, a physical therapy suite or ECT as commonly known, an adult acute inpatient service including a new mother and baby unit, a high dependency unit, a statewide eating disorders service, outpatient consulting and a translational research unit which is operated by the University of Sydney. The completed developments include shell space at level 1 and 2 for future health service usages, and the interior design concept, adaptable functional planning and well-considered interior design details are executed to meet the complex needs and performance requirements required for mental health centres, as referred to in Mary's last discussion. This is just a section through the building, and in Australia traditionally, and in many other parts of the world I should say as well, traditionally buildings of this type are single level and often institutional in their look and feel. Generally they're also greenfield development sites with abundant space for recreational courtyards. For our project this was not the case. Our challenge was to resolve the competing limitations of the site, the prescribed functional requirements and the need to reinvent the institutional interior perception of buildings of this type. This is the typical ground floor plan. So we basically, the dense inner urban location, the complex program and the intense brief and the scarcity of development sites in the precinct necessitated a deep plan and multi-level response. So we used absolutely every single part of the site that was available. The challenge included how to include outdoor recreational spaces at different levels across the deep floor plates. A unique solution is achieved through staggered external courtyards that step at each level to a rooftop garden. So we've heard a lot about rooftop gardens and the benefits of this across the conference. This is one of them. This is one of the typical floor plans with inpatient units within it. The flexible and adaptable space provides a range and choice of accommodation. The centre includes spaces to manage new clinical models to de-escalate patients, integrating low stimulus rooms, retreat spaces and activity areas to encourage interaction, communication and collaboration. We don't have seclusion rooms on the inpatient unit floors. The only area that we have a seclusion room is actually in the emergency assessment unit. The design includes a high degree of adaptability to the different needs of patients, including gender separation capability and flexibility in patient bed type and designation. This is the emergency assessment unit. The emergency assessment unit is where the most acutely unwell patients may first visit the centre. Units of this type are typically highly stressful environments for patients, staffs and carers. They must also be most robust in terms of the physical performance criteria of all fit-out elements. Our approach has humanised the interior of the area. It is enhanced by imagery and simulated scenes of trees, clouds and water. This is the adult acute lounge. Patient corridors are considered as a street and incorporate seats, images or urban scenes, with each bedroom having their own address incorporating a letterbox or street number. The interior design explores the fabric of a neighbourhood and community as a network of living, work and recreational spaces which are connected by streets and places to encourage social interaction. We also challenged the notion of a staff station. This is a key element of the interior design is the completely open staff stations to facilitate accessibility and interaction between staff, patients and carers, thereby deinstitutionalising the notion of the typical staff base, which we see in most healthcare settings. The staff base becomes a consultation point and a touchdown point. As an example of the success of this model, I recently experienced some patients in the mother and baby unit having a manicure at the staff base. This is in the women's and children's unit. And patients also were spreading out the newspaper in the high dependency unit, reading at the adult acute staff station. We think it might be working as a touchdown point. Patient bedrooms. So many small ideas at home are included. Design elements include open shelves, inbuilt photo frames, ottomans and warm fabrics and furnishings. We've also used colour, graphics and local settings in many different ways. They're used extensively to reference the local community, to engage with the neighbourhood. Images of Sydney terraces, city scenes and natural landscapes have been included throughout the centre. In terms of courtyard design, a unique solution is achieved through the staggered external sky gardens. The external green space engages with the interior at every opportunity possible. Transparent yet secure screening, which is in fact 4.5 metres high, allows access to spectacular city views and promotes outlooks for patients, staff and carers. I hear the view on New Year's Eve with the fireworks over Sydney Harbour was spectacular from the unit. The external green spaces engage with the interior. We have a seamless linkage between living spaces and green courtyards. The secure courtyards become recreational destinations within the neighbourhood for the community of the centre. I'd like to move on to case study 2, which is in fact the acquired brain injury unit in Melbourne. It's part of the Caulfield campus of Alfred Health. It's a $36 million development and it commenced in October 2010 and it opened in August 2014. The project includes 42 inpatient units, inpatient beds, an integrated inpatient and outpatient rehabilitation facility and a transition living service. So a little about this model of care. Now we came to the table with and our client had a very well-developed model of care. We were very lucky. The model evolved from focus groups participation, including clinicians, community and disability service providers, consumers, carers and advocacy groups and academics. Features of the model were typically patients would have a severe or catastrophic diffuse brain injury. They'll be stable or they may have ongoing needs. Opportunity for interdisciplinary rehabilitation is an important consideration. Access to low stimulus or a secure environment is a key part of the model. Post-traumatic and or neurobehavioural issues are also common to the patient. So we have complex comorbidities and the care needs were not being met in any other subacute rehabilitation services in Victoria. And their extended stay period is usually in excess of 3 months or more. The key themes of the model included community integration and reintegration, transition care, families and carers as partners, patient-centred care, holistic and intuitive healing and teaching, training and capacity building. The model of care was further enhanced by international benchmarking. The Alfred team embarked on a local and international study tour where they looked at 5 services in the United Kingdom and 3 services in Canada. The project team analysed the components that did or didn't work in the existing centres. This is, it's developed over 2 levels, and this is essentially the singular, well, it's actually level 2 due to the level difference, which shows the split between the front of house areas, low stimulus area, general inpatient beds, discharge preparation, integrated rehabilitation facilities and the staff facilities. It's a very rational plan, and one of the drivers for the rational planning was in fact the nature of the patients and the need for ease of wayfinding throughout the facility. Courtyards are used to create the secure environments for the patients. So we had lots of ideas for theming and spaces in this building. We have activity courtyards, horticultural therapy courtyards, lush green spaces, private and secure areas. We have a focus on social activities, barbecue facilities, and integration of indoor and outdoor spaces, and mobility courtyards as well. There's a snapshot of 2 of the courtyards. The low stimulus area is a particular zone within the building. It comprises of 8 single bedrooms, cat and kitten doors to all bedrooms to prevent barricading into the rooms, and anti-glare features with darkened glass. The low stimulus area includes dedicated courtyard access, a secure suite with its own courtyard and CCTV, anti-ligature fittings, as well as a 3-bed swing zone for additional bed capacity. Our single bedroom design as well. We developed this from first principles. Single bedroom varies between 18 and 20 metres squared, and we arrived at a 7 metre squared ensuite to accommodate larger equipment and wheelchairs. We also included design innovation to minimise clutter. So the typical 1-bedroom includes extensive use of colour for wayfinding, a window seat and daylight access, and also en-suites are disabled accessible. We also have a desk area which is fixed. We have concealed services which are in a services cupboard. We have a ceiling hoist tracks throughout the room and into the ensuite. And we have shatterproof screens to televisions and luminous bathroom signage. So all bedrooms are single rooms, and this is typical throughout the whole facility. We also have our integrated rehabilitation facilities, which includes a large and small gymnasium, a treadmill with large window with views, and ceiling hoists. The seamless transition of care is an important part of the model, and the inclusion of integrated and co-located inpatient, outpatient, gym and consulting areas are part of delivering this aspect of the model of care. We also have an ADL kitchen, activity room, treatment rooms, and importantly, a family lounge to truly partner in care. I just wanted to show you a video which was produced by Alfred Health for the opening of this facility. Hopefully, it will start. It worked before. Maybe not. I'm not sure what's happened. No? We might move. No luck? It's a shame. No luck, Charlie? Okay, all right. I'll conclude then. So, the cultural contribution of the model of care to the design process is significant. We believe our approach to environmental design for both these case studies demonstrates how alternative models of care can bring improvements to patient behaviour and clinical outcomes. In each case, an innovative model of care, a tailored functional brief and international benchmarking has informed design solutions which desire to be different. A sense of openness, colour and hope is created, and ultimately a positive, salutogenic place for staff, patients and their carers.